Okay, so thank you again for joining us. And we are happy to have our Max consultant, Dr. David McDuff, presenting today. He is a clinical professor at the University of Maryland School of Medicine. Dr. McDuff is also the founding director of the UMB Division of Addiction Research and Treatment and Addiction Psychiatry and Medicine Fellowship programs. And we are happy to have him presenting today. And I'd love to share just a couple of quick things about Max for anyone who is not familiar with Max. So we are the Maryland Addiction Consultation Service. So we are a free service for providers throughout the state of Maryland. And we provide support to prescribers and their practices in addressing the needs of their patients with substance use disorders and chronic pain management. So that includes a phone consultation that you can call with any clinical questions that you may have about a patient that you're working with. We also offer education and training opportunities like this webinar today, as well as waiver trainings. We also offer assistance with addiction and behavioral health resources and referrals. So if you're looking for a resource for one of your patients, you can call us and we're happy to send that information to you. We also offer technical assistance. So if you are either implementing or expanding your office-based addiction treatment services, Max is here to help you with that. We also offer the Max Teleecho clinics, and those are a collaborative medical education through didactic presentations and case-based learning. So each month everyone meets, and it's from providers throughout the state of Maryland, and each month a case is reviewed and discussed together. So it's a great way to network and meet your colleagues throughout the state and learn from our consultants. And I will hand the presentation over to Dr. McDuff. Thank you so much for presenting today.
Thank you, Julie, and welcome everyone. Good afternoon. I hope you're surviving our up and down winter weather. My interest in tobacco cessation goes all the way back to 1982 when I had my first assignment in the United States Army in Germany. A pulmonary doctor and I ran a smoking cessation clinic, and I remember fondly those monthly clinics. We used to do a rapid smoking exercise in the actual cessation clinic, which lasted 3 hours. And there was a young man sitting in the front row, and he was just ripping through cigarettes. We had them smoke as many cigarettes as they could in 3 minutes, and they would get a prize if they won, and he won hands down. And most everybody else started to get nicotine toxic and eyes crossed, looked dizzy. And we said, "How are you able to do this?" He said, "Oh, I used to do this for fun when I was a kid." So today we're going to talk about the different types of tobacco and the different types of nicotine vaping devices. Nicotine vaping, as you know, has become much more popular in the last 10 years and has even made its way into the adolescent populations. In my office practice in Ellicott City, I see a fair number of adolescents, both because I'm a sports psychiatrist, but also as an addiction psychiatrist, and I've had some difficult cases of high school and college age students who had gotten into vaping nicotine recreationally and just found that they were using it every day and that they were using it all day long every day. We'll talk about some of the use trends and morbidity, mortality. Then we're going to go over some slides that'll show you where the nicotine acetylcholine circuits are in the brain that result in the development of a nicotine use disorder, how to understand cravings. Then we'll use a 5-step model to talk about quitting, some motivational strategies, and then medication strategies. There's a reference here on this slide. And Julie, do they get a copy of the slides?
Yes, everyone will be getting a copy of the slides after the webinar.
Good. So here's a new reference that just came out in the Journal of the American Medical Association. And it's a systematic review of all the studies that have been done, up until the time of the review. And it's a very good overview. We all know that tobacco and nicotine use disorders are common in the general population, but they're even more common among persons with serious persistent mental illness and other substance use disorders. And the best outcomes come from combining uh, medication strategies with behavioral strategies. And the evidence base, in particular for the combination, is very strong. These are our learning objectives. We've already gone through these. And these are the different types of tobacco. This one you probably have not seen. This is dry snuff. It is sniffed. And there's an area right at the base of your thumb. There's a little indented area. It's called the anatomical snuff box. And you would take a pinch of this, put it there, and then just sniff it into the nose. This is not commonly used anymore, but this goes all the way back to the 15th century. This is leaf tobacco, used to be commonly used in the 60s or 70s, even sometimes by older, baseball coaches and managers. Oral tobacco has a very strong presence in professional sports, but in particular in baseball. So this would be called chew. And you'll sometimes see a baseball player with a very large, amount of tobacco. It's sometimes mixed with gum, which makes it appear larger than it is. This is moist snuff, that's cured in a particular way so that it does have carcinogens in it, and the incidence of oral cancers in persons that use oral tobacco is much higher than it is in persons who do not use it. There's an interesting aspect of moist snuff. There's a variety of it that's popular in Scandinavia, and about 30% of Scandinavian men use oral tobacco, and they don't have higher rates of oral cancer or precancerous lesions called leukoplakia because the tobacco is cured in a different way. These are just your conventional pack of cigarettes. These are the small cigars. What was interesting in Maryland about a decade ago increased the tax substantially on a pack of cigarettes, but neglected to increase the tax on the small cigars, the ones that also come 20 to a pack. And while smoking rates went down significantly after this public health intervention, the rates of use of the small cigars, which were not taxed and still were $2.50 or $3 versus $7 and $7.50 for the tobacco cigarettes. This is a bit of the history of the development of the electronic cigarette. This is the first generation device, and you can see why it was called an e-cigarette. It was made to look like a cigarette. So there's a battery here, and all of these are designed in a similar way. There's a cartridge that contains nicotine in a liquid, and it's this liquid that is a cause of concern. There was an outbreak of severe respiratory distress syndrome back in the late spring, early summer of 2019, where there were 2,000 hospitalizations, 200 deaths, and it was thought to be due to the liquid in there that carries the nicotine, not the nicotine itself. And the carrying liquids for nicotine and for cannabis tend to be the same. One liquid that was implicated was vitamin E acetate. The more common one is glycerin or glycerol, and it's not at all clear that this is safe for our lungs when it goes into in a vaporized form. So the second generation pens had an improved battery. You could adjust the voltage, which would adjust the amount of vapor you would get, and the cartridges are refillable. These are readily available on the black market, and the fact that any person, even a high school student who's selling it to other high school students, can make up the nicotine in a liquid. These were the devices that were implicated in those severe respiratory distress syndromes. This is the newest device called the Juul. That's why vaping nicotine has been called juuling, because it quickly captured more than 90% of the market share. These are the little pods that are replaceable. So you use it up. They have different flavors. I've never been a smoker, but I actually tried the Juul, and I was surprised how smooth it was and how easy it went down. There's not nearly as much vapor with the Juuling device. Now, the Juul, the company, was started by two former smokers, and they were implicated in advertising that was oriented toward adolescents with some of their flavor profiles, and they were forced to take some of these popular flavor profiles off the market. If you look at smoking a typical cigarette and what happens to the nicotine serum level, you can see that you get a very rapid rise in the serum nicotine level. And that's true of any substance that the route of administration is through inhaling. It goes into the lungs very quickly and then straight to the brain. So it takes just 7 seconds for first nicotine, if you're smoking, to get to these circuits in the brain that are implicated in the development of nicotine dependence and a use disorder. These are the different types of nicotine replacements, and you can see that the nicotine nasal spray, which is available by prescription, has the profile that most closely approximates that of a cigarette. The gum, the inhaler, or the tablet. The inhaler's available only by prescription, but the gum or the tablet are available over the counter. You can see that the patch here has a negligible amount of nicotine after an hour. And many people don't know, when you're advising a patient, they should understand that it takes 3 full days for the nicotine level to get up to about this point. So they need to supplement with short-acting nicotine replacement in those first 3 days. A lot of people get frustrated and go back to smoking because it doesn't help them with their cravings. But the explanation for that is just that it takes 3 days to get up to that steady state level. This is just a slide that shows that if you continue to use various substances, how likely is it that you'll develop dependence on that substance and then a use disorder. And you can see, even compared to cocaine, nicotine is a very highly addictive substance, the most addictive substance. And it's one of the explanations for why it's so hard to quit and why it makes such huge contributions to morbidity and mortality in the United States. So it's not all lung cancer, but you see heart disease, coronary artery disease, resulting in heart attacks. You see a large number of individuals with chronic obstructive pulmonary disease. Even some other cancers like colon cancers that you might not think are associated with tobacco use are in much higher rates than individuals who do not smoke. And what makes the cigarette smoke so toxic is these combustion products that get released. They're mainly the nitrosamines, but there are a large number of toxic substances that are released in tobacco smoking. The rates have come down substantially since the middle 60s. These were our original goals, to get down below this the 16% line for youth and 12% for adults, and well on our way until we got other products introduced. We do know that smoking is more common in men than women, more common in those with less than a high school education, and more common in those with in lower socioeconomic levels. Smoking tobacco use rates also vary substantially by state. you can see that, these states in this area, the typical tobacco growing states, you may remember if you're a Maryland resident that it was probably 15 years ago, Maryland essentially banned the growing of tobacco in the state of Maryland. Most of the growing was done in a traditional way on the Eastern Shore, and they essentially bought out these farmers and got them to switch over to another cash crop. Most of them switched over to soybeans, which were not as lucrative, but they gave them a one-time payment to buy them out of the tobacco industry. So, if you have tobacco growing in your state, it's just much more likely that you'll be a cigarette user. The circuits in the brain where nicotine goes to produce its reinforcing effects, its pleasurable effects, which for some is stimulation and energy lift, for others it's relaxation, de-stressing. But like many other substances, namely cannabis and opioids, there are different type of opioid receptors. And if you study the effects of nicotine on persons in the population, you see a wide variation in the effect of nicotine on individuals. Some individuals are very sensitive to nicotine. I would raise my hand and say I'm one. If I'm in a room with smokers, not only is it irritating, but I've smoked a cigar or two in my life and learned better for having done it. I'm extremely sensitive to the toxic effects of nicotine. In fact, I went on a family vacation in Key West, and if you've ever been to Key West, there's a place called Mallory Square where the cruise ships come in, and every evening right at sunset, there's street performers there. So at a restaurant, my wife and 4 kids to go eat fish, and I saw a person rolling a Cuban hand-rolled cigar, and I thought it was a great idea to smoke it up. And I got so sick, I had to fall down on the ground, and I stayed sick the entire night. I didn't vomit, but I felt dizzy and nauseated, and I had a pounding headache, and that was the last cigar I smoked. That was about 20 years ago. So the way I've come to think about this is that each individual has a different distribution of the various subtypes of receptors, and some are likely producing side effects, and some are likely producing positive effects as experienced by the individual. And these are somewhat randomly distributed just through biovariability in people. This is a section of the brain this way, so right through the ear, looking at it, say, from the front. And the darker red and orange areas are where these nicotine receptors are distributed. So you can see that they're in the cortex, diffusely throughout the cortex, and also in the midbrain. This was an eye-opening study and slide for me. What this is a cut through the brain, this way, where you're looking at it from the top down. So it's about the middle of the brain looking down on the top of the brain. And you can see this dense cluster of receptors. So these receptors are radioactively tagged, and that's why they're lighting up. And when you start smoking, the nicotine displaces the radioactive tag, and you can see what happens when you start smoking a cigarette. So one puff, occupies, 50% of the receptors. 3 puffs, probably 70% of the receptors. One cigarette occupies, 90% of the receptors. This is why persons who smoke typically smoke a few cigarettes very quickly in the morning. I was in the Army for 28 years, and my sponsor when I went to Germany was a guy who was about 5 years older than me. He had been a lifelong smoker of Camel's no filter, 3 to 3.5 packs a day. And I would go on ski vacations with this man and his family, and he would always wake up in the middle of the night and go urinate, and he would light up a cigarette and take a few puffs and then go back to sleep. I always thought it was the strangest behavior. I never told him that, but 30 years later, I figured out why. He was going to get his nicotine blood level up. It's not well known that nicotine dependence is a very common cause of insomnia. Nicotine is short acting, and when that nicotine serum level drops in the night, you can actually get the activation of withdrawal symptoms. So it's why some individuals wake up, take a small dose, but you can see from this slide that a small dose is really all you need. There's a scale for determining nicotine dependence called the Fagerstrom scale. And the most sensitive question on there is how soon after awakening do you smoke? And so if it's within 30 minutes, we know it's a driven process. The nicotine serum level is dropped in the night and the person wants to get that. And smoking the depth of inhalation tends to result in a fairly steady nicotine serum level all day long. Some individuals who know that they may be awakened in the night will actually smoke up or even put in a dip of oral tobacco just prior to bedtime so that they'll have nicotine on board and they'll be able to fall asleep more easily. So what's true of nicotine is true of the other addictive substances. This is the configuration of the brain circuits in the non-addicted brain. So the control circuits in the front part of the cortex are strong. The drive, which we call this area the go brain. It's not, something has not been identified as critical for functioning, but you can see this transformation. Control circuits reduce in their influence, drive circuitry and the relevance of the importance of this to the individual, and memory tends to get stronger, but it's mainly for the positive effects. And on the flip side of that, the negativity is quickly forgotten.
Dr. McDuff, we do have a question in the chat, and we also got a comment that you have great pictures on these slides, so thank you. And we have a question. Is there a geographic, racial, or ethnic distribution in the nicotine receptor subtypes?
I haven't heard specifically that there's a specific pattern of receptor subtypes in any ethnic group, or by gender. I just think in more general terms, it varies substantially, as many things do, in a biologically diverse population. But I don't know of a study that has looked at that. All right, so what about opportunities for intervention? As I said, I have an office practice in Ellicott City, Maryland, plus I've worked down at the University of Maryland School of Medicine in the addiction division for 33 years. And each year in my office practice, twice a year, I will ask, those that use tobacco, are you ready for a quit attempt? One of my long-term patients, I just met with him last week. And I said, Charles, are you, planning a quit attempt? He said, I'm glad you asked. I'm planning one next month. And he already knows what he's going to do. He's tried varenicline, brand name Chantix. He's tried bupropion. Originally, when it came out, it was rebranded from Wellbutrin to Zyban. Very unusual for the FDA to rebrand something. I'll explain why in a bit. But he'll be using 2 nicotine patches and short-acting nicotine gum. No, he actually uses the nasal spray. So he has a prescription for the nasal spray. And you might ask, well, why does he use 2 patches instead of 1? So he's using 42 milligrams, which might sound like a high dosage, but he's one of the rare patients in my practice who actually went to a 7-day residential treatment program in California. I think he paid $4,000 to go there. And they discovered that he was a rapid nicotine metabolizer. And so the result of that is that his nicotine replacement gets metabolized more quickly than other individuals. And so he needs a higher dose. And for the first time ever, when he doubled the dose, he finally got a relief of his cravings because he had enough nicotine, to steadily occupy those receptors and settle down craving. It's mainly those dense cluster of receptors in the middle of the brain that are responsible for the cravings and urges. So you have ample opportunity, to intervene, whether you're in, primary care practice setting or mental health care setting or a substance use disorder setting. There's so many individuals who begin treatment for a substance use disorder who also have a tobacco use disorder. It's often delayed for a bit, and I wouldn't argue with the wisdom of doing that. Most individuals have had a history of smoking that dates back to their teens or early 20s, and for them, the focus of, say, cocaine or opiate use, is just much more important, and you just worry that you might destabilize them. But after a year's worth of abstinence, many of them will have already cut down, and they'll be open for a trial of giving up their tobacco as well. The treatments exist and they're effective, particularly if you combine behavioral strategies with medications. So this is just a little 5-step approach. I purchased a larger monitor since I was spending so much time in the office because of the pandemic. But I've always just popped up these slides in my office with the patient here, and I'll just go through them. I start with the slide here. I also explain some of the earlier pharmacology and the rationale for understanding cravings and withdrawal symptoms. So getting ready, most people will set a quit date a month or two out into the future, and then generally they'll begin to reduce their smoking over that period of time. So we'll often ask them to, change something about your environment. Say maybe you're going to give up smoking in your car. So get your car, detailed, have it smelling nice and fresh, and then just don't smoke again. Some studies have showed that smokers smoke about 1/3 of their cigarettes in their car. And so it's a common place to smoke, smoking in the morning, smoking in the evening, smoking after a meal. So you identify these places, and one strategy is just to chart your smoking for a day before you begin to reduce it. And it may surprise people to just see how they're clustered in certain situations. And then you begin to change, the situations. You no longer smoke in those areas. So if I set a quit attempt, say for the 1st of April, and I smoke 2 packs a day, most individuals are going to be down to a pack a day. You review past quit attempts, what worked, what didn't work. You also encourage them to go talk to other people. Do you know anybody who might have quit more recently? Can you give them a call or send them a text or an email and find out what worked for them? So if you network around a little bit, and then once you quit, you don't smoke. You just hang in there and you rely on the individual working with you, to do something that helps with cravings. These are just some old figures. I'm old enough to, remember Look and Life magazine, but this is a classic picture from the 60s, an attempt to glamorize smoking for women because far fewer women in the 60s and 70s smoked compared to men. And this would be a full-page ad you would see in these large print magazines. They were probably 14 by 18. And the one on the left is just a little reminiscent of how our rapid smoking exercise in the smoking clinic did. And I told Julie yesterday, this is also smoking conehead style. There was a skit on Saturday Night Live when it first came out with Jane Curtin and Dan Aykroyd, and they would just tear open a pack of cigarettes, both ends of it, and light up 20 cigarettes all at one time. You should look it up on YouTube because it's quite funny. So get support and encouragement.
Sorry to interrupt. We do have a couple of questions in the chat. We're getting a lot of great questions through this, which
All right.
thank you, everyone. One of them was about the patient that you were referring to earlier, who was using 2 patches a day.
Yes.
They're wondering, is this patient paying out of pocket, or were they able to get the insurance to pay for the 2 patches a day?
It's the only program I've ever heard of that focused exclusively on tobacco, and it was definitely out of pocket. Yeah, he had been trying for 10 years to reduce his smoking. He used to be a 2-pack a day smoker. Now he's down to about a half a pack or even less a day, but he still, hasn't had that long period of time of abstinence. No, you wouldn't see health plans, and you wouldn't even see these sorts of programs that are available. My hope would be that some residential and outpatient programs that just can, become more knowledgeable and skilled at helping people with tobacco cessation.
Great. And then one other question that we have in the chat is, has EVALI, the vaping-related pulmonary disease, really disappeared? Did they definitively identify the device that causes EVALI?
It seems to have faded, and it looks as though it was just black market devices of that 2nd-generation type that had refillable cartridges. And I've talked to people that own vaping shops who mixed up their own nicotine. Nicotine is very toxic when it's completely concentrated, and it can even be absorbed through the skin. So there have been some instances where infants have actually, taken some of the liquid from one of these refillable devices and died of nicotine toxicity, usually from its cardiovascular effects. But they think it was in part vitamin E acetate. It's definitely not the nicotine, and it's not the cannabis, because there was a mix of both of these, but the carrying liquid seems to be similar. The juuling devices were not implicated in this. You can see you get more puffs for a lot less volume. The 2nd and the 3rd-generation devices, if you would see someone use it, you would see a very large, plume of vapor in front of them. So, but I would just, say if you're treating an adolescent or a young adult and they're intent on using a vaping device, don't use, a black market one, a cheap one, and don't use one that, unless you know who's filling it up and you know that they have a master's degree in chemistry. Okay, so in terms of getting support, you just tell everybody. Tell family members, friends, coworkers, hey, I just wanted to let you know that I've decided to, quit smoking or quit dipping. I'm going to stop the 1st of April. I'd really appreciate your support. And then I tell them to go a little bit further. Do you know anybody who might have quit, in the past or more recently? And most people will know somebody who quit, and you connect them up. You tell your healthcare providers, even your pharmacists. It's not as easy for them to talk to you these days because they're backfilling, many prescriptions. But you'd be surprised what people know about ways to stop. And they can just sort of recommend something. You can explore it and then maybe even try it. We know that any kind of behavioral intervention, when Chantix first came out, varenicline, there was a requirement by the pharmacy plans that you had to connect with a weekly telephone counseling session that was very brief. And at first, I resented my patients having to do this. I said, I do the therapy, and my patients resented it a little bit. But then when they started engaging with this other individual who was knowledgeable about behavioral strategies for quitting, they said, I really like talking to this person. So I completely changed my view about it. And, connecting otherwise, at University of Maryland, Baltimore County, the Department of Psychology is run by Carlo Di Clemente, who's a very well-known addiction psychologist, who's the co-creator, along with James Prochaska, of the stages of change model, which was originated with smoking cessation as its target. And they have grant funding to operate a website and a hotline to connect people with resources to help them quit smoking. And you learn new skills and behavior. So distraction works. So talking, walking, if you have a craving, drink some water, pop a piece of gum in your mouth, whether it's nicotine replacement or not. One of the things that I've discovered works pretty well is I routinely teach breathing techniques, both for stress control as well as introducing energy into the body. So a typical exercise to teach someone using breath for stress control would be breathing in through the nose and then out through the mouth. And there's an exercise that I call triple clear. So it's in through the nose 4, out through the mouth for 4. Then it's in 4, out 6, so longer, in 4, out 8. So you're lengthening the exhalation. It's a little bit like walking downstairs, and it's nicely de-stressing, because in a way what you're doing is you're gathering together all the energy of the stressful activation and providing a pathway for it to exit the body. So it would look like this. You clear first, in smooth through the nose just to the collarbone, and then out 4. It's smooth, but I connect it with an inner rhythm by rocking. In 4, just to here, and then out 6. In 4, out 8. And so you pause at the end of the 8. And it's a real quiet moment. You'll notice that you don't really need to breathe. That's because you've cleared off enough carbon dioxide. Most people think it's low oxygen in the blood that triggers us to have to breathe. It's actually high carbon dioxide. So if you slow your breathing down, clear off the CO2, you'll nicely quiet the level of activation down. There's also a bit of an odd breathing technique that introduces energy, and I've used it as a cravings buster for many, many years. It's called nasal hyperventilation. So you're going to hyperventilate in a controlled way through your nose. It does look silly. So if you want to, attract attention, do it in public. If you don't do it in public. But it looks like this, and you'll see how fast you can breathe. So big breath in. Now you flip it to relaxation. Physiologically, what this does is it clears off a lot of CO2. It shifts the pH of your blood to more alkaline. You develop a respiratory alkalosis. And it's a lot like resetting your computer when you've opened up too many programs. So when you have a craving, the circuits in the middle of the brain, they light up. They turn on in 0.2 of a second, and they stay on for 10 to 15 seconds. But I've noticed by teaching individuals these breathing techniques, either relaxing or energizing followed by relaxing, it'll often just reset that craving and shorten its duration. You change your routines. If you always smoked after coffee, try another beverage, which that in and of itself may be difficult too. But there may be certain foods where the association with tobacco would be stronger. If you smoke in your car and you smoke just almost automatically because you drive the same way to work, maybe not these days. So if you go from one room of your house while you're working online, then you walk in a different way, or start out in one room and finish in a different room. But we're teaching stress control, massage therapy, which you can do yourself, reading, meditating, mindfulness, music, having your pet be around, certain fluids. Sometimes when you have a craving, drinking something that has a strong, bold flavor to it, like certain types of teas, or maybe cranberry juice, maybe something you wouldn't ordinarily think of, but just that activation of flavor and taste can sometimes be helpful. And then you just focus on doing something enjoyable every day. Okay, these are the common medications that have been studied. We've got nicotine replacement on the left. So some individual, the nicotine gum comes in 2 milligrams and 4 milligrams. There was a while where the 4 milligram was by prescription only, but the 2 and the 4 are now available over the counter. And if you've never seen this, it looks just like a square piece of gum in a little foil pouch that you pop out of a blister pack. And the nicotine is embedded in a resin in the gum. And you don't chew it like you do chewing gum. If you chew very fast, you release too much of the nicotine all at once. And you should chew it and park it. Nicotine is a local anesthetic. So you'll actually get some tingling in your lips and gums. And that's how you know the nicotine's been released. So you get a little tingling, you park it between your cheek and gum, and then you try to make a piece of gum last an hour. As I said, if you're going to use the patch, you supplement with any of the other short actings, the nasal spray, the nicotine lozenges, the gum, or the inhaler. And then we have bupropion, just a history lesson for a minute. Wellbutrin came out 30 years ago, and it was only in the short-acting form. And it turned out as an antidepressant, the dosage was way too high, and the short-acting form had a serious side effect. About 5% of individuals developed for the first time in their life a seizure. And so these began to disappear when they developed the extended release formulation. So next came the SR, sustained release. It's still not long acting enough to use once a day. So it's a twice a day dosing, and it was rebranded from Wellbutrin, which had gotten really bashed in the marketplace because of the risk of seizure development. So they changed the name to Zyban. Now we have the extended release. This comes, I like this because it comes in 100 milligrams, a lower dosage, and I'll sometimes introduce this just for use during the day. So you can definitely combine bupropion with nicotine replacement, and the literature is very clear that combination strategies work better than one strategy alone. So 2 forms of nicotine replacement, typically the patch and some short acting, or bupropion and nicotine replacement, or bupropion along with varenicline. We don't use varenicline and nicotine replacement because varenicline is a nicotine agonist. So it goes to those same receptors, produces a nicotinic effect, and you'll get, quickly nicotine toxic if you're both. And partly that's what you want to happen when you use varenicline, and I'll go into some detail about how to use it. You want your patient to start experiencing the use of their tobacco product in a negative way. And so you get some competition at those receptors and you get them, super saturated, and you get the toxic effects of nicotine that I described. So, and most of my patients who've had success with varenicline said, I just don't like to smoke or dip anymore. It's just not pleasurable the way it used to be. And they're thankful because they're wanting to quit. So that shift from a positive experience to a negative one, and most people who gotten into chronic coughing and recurrent upper respiratory infections who are smokers, it's not so positive anymore, but this adds another negative dimension to it. So these are just some studies that show that quit rates are better with combination, and that's even true of bupropion and varenicline. So this first study by Ebert shows that by combining varenicline and bupropion SR, that's 150 twice a day. The varenicline is a milligram twice a day, that the quit rates were substantially higher. Because traditionally persons, the Evans study, seriously, persistently mentally ill persons have far higher smoking rates. I used to be the clinical director at Springfield Hospital Center, before it went smoke-free, and about 60% of the patients there were current smokers, and so they were all allowed to go out for smoke breaks. For that matter, about 30% of the staff were smokers, and they went out on smoke breaks with them. And they were more unhappy with the change to a smoke-free facility than the patients were. But this was a trial to demonstrate that varenicline was not, didn't have adverse effects in persons with chronic schizophrenia or chronic psychotic bipolar disorder. So what was nice about that, it was a long trial. It helped with smoking cessation, but it was very compatible with the antipsychotic medications that these persons were taking. This Eisenberg study is a nice trial of starting varenicline while somebody's in the hospital, say for elective surgery, as a strategy to control their cravings, but then continuing it, once they left the hospital. So this 47 is starting it in the hospital versus starting it after they left the hospital. It just had, and that's a pretty strong abstinent rate, that many weeks out. And then this, the nicotine metabolite ratio really gets at this notion that some individuals are rapid metabolizers. So if you've ever had an insurance physical and they ask you, are you a current smoker? And you are, and you lie, and you say, well, no, and you think you're just going to stop for 2 days before they draw your blood. Well, there's a metabolite of nicotine called cotinine. And so we can learn from this nicotine to cotinine ratio, the different groups that are rapid versus slow metabolizers. And it's those rapid metabolizers who may need a higher dose. This was just a prevention photo to try to get people to stop dipping, because if you've ever seen someone dip, snuff, moist snuff, they spit a lot. So in a baseball dugout where it's permitted, it's banned in the minor leagues. It's not fully accepted in the major leagues, but it's not banned. You'll see some, spitting in a cup. The worst thing is if they spit on your shoes, because it's just this nasty mix. If you haven't ever tried moist snuff and you're curious, it's not so easy to put a pinch and compress it. So most individuals take that tin and pop the tin in their hand so that it begins to pack it down so that it's much easier, because a lot of it is finely ground. More surface area, which makes it very easy to absorb. In addition, the pH is controlled. The more alkaline it is, the more free nicotine, the more easily it is absorbed. So varenicline comes in 0.5s and 1 milligram. And you can, if you're prescribing it, you can prescribe 0.5 twice a day. Give someone 60 with refills. You could prescribe 1 milligram twice a day. You want to titrate them up. There's a starter kit that gets them up to 1 milligram twice a day in 5 days. And to me, it's just way too fast. And some people get toxic. One of the more common side effects for some people is real vivid dreams, sometimes upsetting dreams because they're so vivid. But what I've tended to do is I'll say, continue to use, continue to smoke, continue to dip, start out with 0.5 just during the day. So I'll give a prescription for 0.5 twice a day, 60 with refills, 1 milligram twice a day, 60 with refills, and they'll go get the 0.5 filled, and they'll just use it during the day for about a week or two. And this will tell me how sensitive they are to the varenicline. If they're more sensitive to it, then often 0.5 twice a day is enough. If they didn't notice much effect at all while they continued to smoke while taking it, then they're likely to be someone who's going to need 1 milligram. But you could use 1 milligram during the day and 0.5 milligram. So don't rule out the possibility that 1.5 milligrams a day. So much like buprenorphine is to opioid pain medicines or heroin, varenicline is a partial agonist that goes to those nicotine acetylcholine receptors that I showed you earlier. And it's relatively long acting. So it locks onto those receptors. It has strong receptor affinity. And that's how it blocks cravings and manages withdrawal symptoms. And it's quite good for doing that. This was the original trials compared varenicline with nicotine replacement with placebo. And you can see that the abstinence rates in the traditional clinical trial was 9 to 12 weeks, but an abstinence rate of 25 or 30% a year later is really quite a good abstinence rate, and gets that up there with abstinence rates for persons who stay retained in treatment. So you may combine the bupropion. You can use the extended release. What I don't like about it is the lowest dosage is 150 milligrams. And for some people, that might be too stimulating. You take it during the day, not at night, because it can be activating and interfere with sleep. But I tend to use the SR and start with just a single dosage during the day, just like I do the varenicline, and then build up to twice a day if the person tolerates it just fine. So as I said, we're not using varenicline and nicotine replacement together because it causes nicotine toxicity, and you really have to alert your patients to this. Some of them will just assume that nicotine replacement is an absolute medication strategy, and that whatever else they try, they're going to continue with the nicotine replacement. And then varenicline can be used with bupropion, but I would take the approach that I've advised, which is raising the dosages more slowly. DIP is common in sport. It's common in the military. More and more women are using tobacco products, including cigars. So the landscape is changing. But we've got to prepare someone for what are their triggers and, to expect relapse. The original studies using the stages of change model by Prochaska and DiClemente, highlighted for us that many individuals need 4 or 5 quit attempts before they finally have, an extended period of abstinence. So you don't want them to get discouraged. You simply want them to, lessons learned, and we'll try, added strategies the next time. Many people who want to stop smoking, one of the barriers are they're worried about weight gain, but the long-term studies show some gain, some lose, most, the weight stays the same, but usually the weight gain is modest and can be managed off by, diet and exercise. Negative emotions, stress, typically are common relapse triggers in nicotine use disorders, just like they are in other substance use disorders. And the first 3 months are really the critical period of time. About 2/3 of all relapses occur in the first 90 days. Okay, so we've got a few minutes left. Any final questions?
Yes, I just wanted to share, we just got a comment in the chat just saying that it's very good to hear that there need to be multiple quit attempts. And reminder to everyone that you can put your questions in the chat. I do have one from a little bit earlier. They asked, based on current knowledge of the pharmacogenetics of nicotine metabolism, could you comment on the efficacy of genotyping patients for the CYP2A gene to determine metabolic profile before starting tobacco cessation treatment?
I've not seen how clinicians could access that. The person who asked the question probably knows more about it than I do. I've not personally done that. I've been a little cautious about genotyping for medication specificity. I'd be a little bit more, say, for antidepressants, for example. I don't think the evidence base for genotyping to lead you to a specific antidepressant is any better than taking a family history and finding out which, SSRI or SSNRI worked best for, one extended family member. But I think that's the wave of the future, because it certainly would be nice to know, what the metabolism profile of an individual is. If that individual asks the question knows more about that, I'd be pleased if he'd share it with the group or share it with me. My email is on there, so just send me an email directly. Part of the reason I like to do talks and be a consultant is I always find out something new, because there's always somebody out there who's, done some reading I haven't done.
Great, thank you. I will make sure to follow up with that participant and let you know. And just so that everyone knows, I did just put this information into the chat, but just wanted to give a reminder that you will receive an evaluation. It will pop up in your window. We do ask that you fill that out just so that we can have some feedback for this training today. And after completing those, you'll receive your CME and CEU certificate along with the PowerPoint slides by next Friday. And if you have any questions, I've put in our Max training email in there. And we're happy to take a couple more questions. If anyone has any, you can put them into the chat. But thank you so much, Dr. McDuff, for such a great presentation.
My pleasure.
Okay. It looks like there's no more questions coming up, but so thank you so much again, everyone, for joining us today. And if you have any questions after the training that you think about, you can definitely feel free to email us those. I'm also going to put in the Max phone number. So if you have any questions and would like a consultation, you can definitely call us and we're happy to help.
Yeah, I would encourage those who see a lot of persons who use tobacco, particularly pregnant women. About 7% of pregnant women use tobacco products, mainly tobacco smoking. Only nicotine replacement has been studied in pregnant women, but not very well. And the studies were small and the dropout rates were high. There have been no studies using varenicline or bupropion with pregnant women. And so we're a long way off from helping women during pregnancy.
Dr. McDuff, I am seeing in the chat a question just about motivational interviewing, and is this a technique that you find useful?
Yeah, I mean, my entire style is one of being, encouraging, finding natural support persons, in the social network of that individual, you know, getting them to key on the positive aspects. Every quit attempt is a real positive, and there are lessons to be learned from that. Yeah, so just, getting a dialogue going, what's leading you to want to do another quit attempt at this point? What have you learned, that's likely to be successful? What's likely to get in the way? So you identify potential barriers to abstinence or recovery. But that's the style I use in my work with substance use disordered patients. I did a talk. I did a talk on motivational enhancement therapy a couple of months ago. Are these available if somebody wants to see uh, an old talk?
Yes, they are. They are available on our website, which I can put into the chat right now. But yes, they are recorded and available to view on our website. So thank you so
Thanks
much.
very much for attending. Thank you, Julie, for hosting and guiding us with the questions. And you can email me directly if you have a question, or you can route it through Max, either one.
Absolutely. Thank you so much, Dr. McDuff. Have a great day.
All
Thank
right.
you, everyone. Bye-bye.